So just think out loud. And,
right. All right. We're looking at a slow heart here. It's going at about, it's 6 boxes, so it's going at about 50. And the most striking thing is ST segment elevation in the inferior leads. The PR interval is at the outer limit of normal, maybe just barely abnormal, as looking at the PR in the inferior and lead 2 and lead 3. Now, significantly, there is nothing wrong with the ST segment in the right precordial leads, as would often happen if this was a true blue acute inferior STEMI. And so we have to think of other diagnoses, and these would include pericarditis, and this strange phenomenon that Anselevich has been talking about of the J point. This is not classical early repolarization because it doesn't show up at all in the chest leads. So it's not in that category. So I would finish saying this is abnormal ECG with sinus bradycardia, ST segment elevation, rule out ischemia.
Good.
And that would be it.
Good.
All right, now here is an electrocardiogram, and my first reaction to it is that the leads have been reversed. In other words, lead 1, Eindhoven lead 1, has a negative P, a negative QRS, and a negative T. The only time you see that is either with reversal of the arm leads. In other words, the left arm lead was put on the right arm and the right arm on the left. And but there is another circumstance, and that is with somebody with situs inversus, with their heart on the wrong side. But that isn't it in this case, because the chest leads are the way a normal sequence occurs. So this is categorically arm lead reversal, and therefore it is not an acceptable electrocardiogram.
Good.
So here we have a tachycardia. Tachycardia is going at about 200, and it has a wide QRS, and I have no reason to believe that it isn't ventricular tachycardia. And in other words, it doesn't show any of the characteristics of simply a supraventricular tachycardia with an already established bundle branch block. It does not correspond to that in any way. So it is ventricular tachycardia. Now, I do not see evidence of, the next thing we have to do is look for atrial evidence. And in lead 2, there is a suggestion of flutter waves. In other words, of waves, P waves, that are about 1 box wide, actually less than a box, about 4 small boxes wide. But it's only, it's by no means definite. So I would say ventricular tachycardia cannot exclude atrial flutter, and that would be my diagnosis.
Good.
All right. Now here is an electrocardiogram that is in every way normal, except for a little bit of ST elevation starting in V3 and continuing in V4 and V5. Doesn't look really like early repolarization. There is no evidence of pericarditis. The frontal plane ST segments maybe slightly depressed in lead 3. So I would say this is a borderline electrocardiogram with ST segment deviation. Rule out early repolarization, rule out pericarditis, rule possibly a normal, and that would be this.
Good.
So now we have a tachycardia. It's going at 200, and it's a narrow QRS tachycardia. And the first thing we have to look for is evidence of retrograde conduction, because the commonest tachycardia has a retrograde P. I don't see evidence of that in V1 or really in lead 2 and 3. So, and it is too fast to be sinus. The sinus rate, you can't call it sinus if the rate is over 64, and this rate is faster than 64. So this is paroxysmal supraventricular tachycardia, and there's nothing very special about the T wave or the QRS, so there's nothing else to say except what I've said.
Good.
Okay, and now we have an abnormal slide in many respects. First of all, there is right axis deviation, and secondly, there is a wide P wave showing intraatrial block, which could be a manifestation of left atrial enlargement. And there's right axis with the axis of the QRS is about plus 130, and there is an increased RS ratio in V1 and V2. So all of this points to right ventricular hypertrophy, and that's about as far as one can go.
Okay.
So this is RVH,
okay.
Right ventricular hypertrophy with probable biatrial enlargement. Both atria are enlarged.
Good.
All right, now this is, I hope this is not another example of lead reversal. Once again, we're looking at lead P wave down, QRS down, and T wave down in lead 1. And as I said a few minutes ago, this can be situs inversus. And I'm looking now at the chest leads, and they show exactly what you would see with situs inversus. In other words, the leads, basically you have an RS structure which gets smaller and smaller and smaller the further away you get, because the heart, you're going further and further away from the heart. So this is situs inversus. This is, the heart is on the wrong side. And
Good.
that's it.
Good.
Oh boy. So here's a rate of 150, and gross ST segment deviation. ST segment is depressed in V2 and in the lateral leads also, and it's elevated in AVF, and there's already a pathologic Q wave in AVF. So this is a person with an established inferior myocardial infarction, which is, and it's far into this infarction because there's already a Q wave. So this is acute or evolving inferior myocardial infarction.
Good.
And there is a rhythm disorder that is simply sinus arrhythmia, I think. Doesn't seem to, no, there's hardly any rhythm disorder. All right.
This is news to you.
Now we're in another tracing now?
This is
Okay.
new.
Okay, so now we're in a tracing with deep T-wave inversion in the chest leads, which is a very serious thing to have, and could be a sign of imminent ischemia in the left anterior descending. I cannot call it left ventricular strain, even though there is left ventricular hypertrophy, because it's leaked into V3, and it's mostly symmetric T-wave inversion. So it's we would call this anterolateral ischemia, and it's very abnormal. And that's all I'll say.
Good.
All right, and so here we have, once again, an abnormal V1. The RS ratio is actually positive in V1, and there is a right atrial enlargement shown by the P wave in V2, and we have ST depression in that lead in V2 and V3. So those are signs of right ventricular hypertrophy and strain. However, the axis is not very far to the right. The axis is rightward because it's negative in lead 1. So I would say this is right axis deviation and right ventricular and right atrial hypertrophy.
Good.
Okay, now we have a very irregular rhythm here, and we have a wide QRS and breaks in. First of all, the rhythm is atrial fibrillation because the RRs are grossly irregular. Each RR is different from its neighbor, either on the left or on the right of it. Each RR. So it is atrial fibrillation. And in the middle of it, we have a right axis deviation, a mild right axis in the frontal plane, and then we suddenly have the burst of ventricular PVCs here showing up in the middle of the tracing, just as we start to record V3 and V1 through V6. And these are very tall runs of ventricular tachycardia.
Good.
And because the QRS is wide everywhere, one wonders, is this a patient with atrial fibrillation who has already got an IVCD that widens the QRS? And that's particularly, one wonders that, because there is one space right in the middle where the QRS narrows down. And so that suggests that we're looking at a ventricular tachycardia type of message with a grossly irregular rate. So this would be the strange combination of an abnormally wide QRS in the presence of atrial fibrillation, with additionally PVCs in threesomes occurring right in the middle of the tracing. It's not a very satisfactory solution, but that's all I'm doing for the present.
Good.
All right, now we have, this is the umpteenth tracing that has an increased RS ratio in V1. And it has very little else going on in V1 to suggest right ventricular hypertrophy, and the axis is just plus 90, which is not really right axis deviation. So this is the differential diagnosis. So this is somebody with an increased RS ratio in V1, and that's the main abnormality. And there is a condition which gives you that, and that is progressive muscular dystrophy. And this could be that. Or it could be a very old dorsal myocardial infarction. And that's the best I can do.
Okay. Good. That's all the ECGs.
Okay.